Good morning, everyone. Uh, Today, I'll be talking on some of the congenital viral infections. We have the case scenario, that is a 10-year-old baby presented with mild jaundice. History of normal delivery to a 23-year-old female is present. The mother had no illnesses during her pregnancy and she is not a smoker. She is not alcoholic or drug abuser. There is no family history of genetic abnormalities. On examination, abnormally small head circumference, otherwise called microcephaly, is present, but the CVS is normal, but hepatosplenomegaly is present, and the central nervous system notable for the lack of startle responses to the loud noise, and a CT scan of head reveals intracerebral calcifications. So these are white things are intracerebral calcifications. Here and there you can see these are all. So this is a 10 days old baby presented with mild jaundice who born to a 23-year-old female, and there are no abnormalities or abnormal behavior from the mother, and no history of any genetic abnormalities among their family members, and microcephaly is present. This is a microcephaly, how it appears, and CNS, this lack of startle or immediate responses for the loud noises, and hepatosplenomegaly is present, and CT scan is showing intracerebral calcifications. With this, what we have to learn about. This is one important virus which can get transmitted through the placenta. So this is one among the members of the TORCH panel. That is TORCH. TORCH, I think you know. This is for Toxoplasma gondii. This is for Rubella. This is for Cytomegalovirus, and this is for herpes simplex viruses. So the Toxoplasma gondii, which is a protozoan responsible for the teratogenicity, and rubella also causes for the abnormal structural abnormalities when the baby is in the womb, and cytomegalovirus is one among them which also causes for some congenital abnormalities and herpes simplex. Now we are here, we are going to talk about the cytomegalovirus. The cytomegalovirus, the previous name for the cytomegalovirus was salivary gland virus, because it's mainly seen in the salivary secretion, salivary gland epithelial cells, so it was named as salivary gland virus. And this is the largest virus among the members of the herpes viridae family, and it's responsible for the massive enlargement of the infected cells, and it infects. See this massive enlargement, how you can see here. See here this massive enlargement of the infected cells with inclusion bodies, and it infects mainly the kidney and salivary glands. In vitro, it replicates in the human fibroblast cell line cultures, means it's a cultivable virus and produces cytopathic effects which described like wolf's eye appearance. The cytopathic appearance, effects described as wolf's eye appearance. See, this is the infected cell and how it appears like wolf's eye. Reservoir for this bacteria is the human beings who are either suffering or non-suffering with this particular virus, and source for this infection is salivary secretions and also the cervical secretions, semen, and milk, for breast milk from mother are also infectious, and it can get transmitted through the placenta. There's a transplacental route from the mother to the baby, followed by the sexual contact. Since they are present in the kidneys, followed by the renal transplantation, this is another possibility for the transmission of this particular virus. And the perinatal, this at the time of delivery, also it's possible, and postnatal after delivery also, after delivery after delivery also is a possibility is there for this particular infection transmission. Congenital cytomegaloviral infection, how it's present, we will see now. This congenital cytomegaloviral infection is very severe if infection occurs before the first trimester. If the transplacental transmission occurs from the mother to baby in the first trimester of pregnancy, it will manifest very severely. It infects the liver and also the blood forming organs like bone marrow and other areas are all involved, and nervous system also gets involved. And this cytomegalovirus presents in the form of cytomegalic inclusion disease among the 5% of the infected babies. The most common presentation is petechiae. The petechiae are produced. Sometimes this petechiae or hemorrhagic spots, otherwise called petechiae, otherwise called hemorrhagic spots, will appear in severe form like see here, this is how severe they are. See, these are in the severe form they are seen, and they are known as blueberry muffin lesions. And the baby who are having this kind of lesions are known as blueberry muffin babies. So this is called blueberry muffin baby. And here you can see the hepatosplenomegaly and also the jaundice is present. That's what we are seeing in the case scenario now. And it's less common presentations with cytomegalic inclusion disease or microcephaly. There's a small sized head and cerebral calcifications are present, and intrauterine growth retardation, and premature babies will be born in 30 to 50% of the infected cases, and mortality rate is around 20%. So like this, the cytomegalic inclusion disease may present in most common forms and less common forms, and most common forms are seen in the form of petechiae, and also in severe forms it's also present as blueberry muffin lesions with jaundice, and in less commonly this presents with microcephaly and cerebral calcifications and premature babies. Remember, the mortality is around 20%. Perinatal cytomegaloviral infection, its transmission occurs during the delivery and also followed by the breast milk, and it presents asymptomatically, and these viruses will present in urine up to the ears from these babies. Sometimes it may present in a severe form, that is interstitial pneumonitis. The interstitial pneumonitis, which involves the lung and the interstitium of the alveoli, that's the space between the alveoli, will be affected and produces the interstitial pneumonitis. And especially this interstitial pneumonitis is seen among the premature babies. And in the immunocompromised individuals, this CMV, that too among the AIDS patients, present in the form of chorioretinitis. Choroids as well as retina both are involved, which is a common form of this one, and the gastroenteritis and also the dementia, the loss of memory also present among the immunocompromised individuals. The organ transplant recipients, usually 1 to 4 months after the organ transplantation, the people may suffer with this cytomegaloviral infections. That's why before transplantation, the donor as well as the recipient has to be checked for the cytomegaloviral infections. And again, among the organ transplant recipients, usually they suffer with interstitial pneumonia, which is the most common form. This interstitial pneumonia, otherwise called working pneumonia or atypical pneumonia, this is a very dangerous form of the pneumonias. Of course, in COVID-19 also you can see the same kind of pneumonia where the interstitial spaces are involved and causes for hypoxia. And it also produces febrile leukopenia, and also the rejection of renal allografts are produced. These are all the various clinical manifestations produced by these viral infections among the organ transplant recipients, because these organ transplant recipients will be on the immunosuppressive agents, so these viruses can multiply easily and produces all sorts of clinical manifestations as mentioned. The samples to be collected urine and bronchoalveolar lavage, and they have to be subjected for microscopy where you can see the characteristic cells. See the cells which shows Wolff's eye appearance. These are all the characteristic cells. See the intranuclear inclusion bodies are present, and culture, so as I mentioned already, they can grow on the human fibroblast cell line cultures. After an incubation period of 2 to 3 weeks, you can see the multinucleated giant cells with cell enlargement. See the multinucleated giant cells with cell enlargement are present here. And shell vial technique is another one, where the centrifugation of cell culture with the specimen will cause for the infection of more cells with this particular virus from the clinical specimen, and the viral detection will be very easy by means of immunofluorescent technique. So this shell vial technique means the cell line cultures have to be mixed with the clinical specimen, and you have to centrifuge them. And while centrifugation, the viruses which are present in the clinical specimen gets attached to this cell lines, and then the growth will be more or yield will be more. So once the viruses are grown, the cytopathic effects will be identified by using the immunofluorescent technique. Detection, it's IgM antibody for the early infection and IgG antibodies for the late infection are useful, and CMV or cytomegaloviral specific antigen, that is PP65 antigen from the peripheral WBCs also can be detected by using immunofluorescent method and monoclonal antibodies. That means monoclonal antibodies against this particular antigen. The monoclonal antibodies against this particular antigen will be tagged with the immunofluorescent dye. They will be tagged with the immunofluorescent dye and they can be used. This is a more sensitive method. And molecular methods, of course, this is the ultimate test for the detection of cytomegaloviral DNA by means of PCR testing. No use with acyclovir, but we have to use the ganciclovir, which is the drug of choice, and again it has to be given by intravenous route. And this particular drug undergoes phosphorylation and to convert the ganciclovir triphosphate, which can inhibit the viral DNA. This is the mechanism of this ganciclovir. And phosphorylation is the main step to convert the ganciclovir to the ganciclovir triphosphate, which is an effective form. That will not happen in case of acyclovir. That's why ganciclovir is the drug of choice. And next one is the foscarnet among the people who are resistant to the ganciclovir. Then we can go for the foscarnet. And for the people who are receiving the bone marrow and any other organ transplantation, the immunoglobulins, the cytomegaloviral immunoglobulins may be considered. And another important drug to be given is pseudofovir. Pseudofovir also can be given, and it's the most important point to remember about this is this highly nephrotoxic. So it has to be used very, very cautiously. Important virus causing for the congenital infections, the Parvo virus, and usually these Parvo viruses or the animal viruses, but sometimes they can infect the man, and it may responsible for commonly responsible for childhood exanthemes. Of course, in adults also the some kind of rashes are produced, and in young pups. Among the young pups, usually they produce this in the form of diarrhea, and these pups are main source for this infection. And one most important as far as the morphology is concerned, this is the smallest virus, and it's around 20 nanometers in size. That's why this is DNA virus with a single strand and a non-enveloped virus with icosahedral capsid. So this is the morphology of this particular virus, which is the smallest virus with single stranded DNA, non-enveloped virus with icosahedral capsid. Parvoviruses, parvovirus B19 is mainly responsible for human disease, and the mode of transmission and source is by means of respiratory droplets, and vertical transmission and the percutaneous route of transmission also possible to infect the individuals. And then the replication is they mainly replicate in the erythroid progenitor cells in the bone marrow and results in cell lysis. Erythroid progenitor cells, there's erythroblasts which are present in the bone marrow during the developmental stages of these RBCs, and they attack the bone marrow and results in cell lysis. And they also can replicate in the endothelial cells of the blood vessels. So they replicate in the endothelial cells of the blood vessels. Clinically, it presents as transient aplastic crisis among the children, especially who are suffering with sickle cell anemia, and results in severe form of anemia. This aplastic anemia, transient aplastic. That means the production of the RBCs itself will be affected because it affects the erythroid progenitor cells in the bone marrow and stops the release of functional RBCs. And erythema infectiosum, it's also known as fifth disease, and it's erythema, and it's manifested as erythematous maculopapular rash on the face. See this erythematous maculopapular rash on the both sides of the face, and gives an appearance like slapped cheek appearance. It gives an appearance like slapped cheek. You can see on both sides how it's present red in color. And usually in case of females, the polyarthralgia of hand and knee joints are present. Among the females, this is another problem. Adult females, especially adult females, they suffers with involvement of many joints of the hand as well as knee joints. Pregnancy, if it is during the pregnancy, it results in the fetal death, and spontaneous abortion also possible. And another hydrops fetalis usually produced during the abnormal blood group carriages, but here that is immune mediated. But the non-immune mediated hydrops fetalis is common here. The immune hydrops fetalis is due to the RH incompatibility. Due to the RH incompatibility, the hydrops fetalis is common. That's mediated through the immunological involvement. But here, non-immunological hydrops fetalis is produced if the baby is infected during pregnancy. And the papillary purpuric gloves and stalk syndrome is another important feature here, where the painful and pruritic swelling and erythema on the distal hands and feet, especially in the spring and summer season, you can see. See here, this is like here, then the hand and in the foot. It appears like it's in a painful and pruritic swellings and erythematous swellings on the distal hands. That's why it's known as gloves and socks syndrome, like gloves like and socks like syndrome. So this is gloves and socks syndrome. It's papillary as well as purpuric rash is present in this involved areas. The lab diagnosis, the specific IgM and IgG antibody detection can be done, but the best is PCR testing for the diagnosis of this particular viral infection, and viral isolation is not possible. So this is not cultivable virus, and there is no specific treatment, and vaccines are available only for the cats and dogs. And remember, these are the transmitting agents of this particular virus. So the pregnant women always have to avoid the contact with these pets, because they are the transmitting agents. Usually among the pet animals they produces only diarrhea, but in case of human beings they will be manifested in the form of aplastic anemia, and also the slapped cheek syndrome, and also the papular socks and glove syndrome also produced here. Remember, this contact with these animals, especially during the pregnancy, is more dangerous. Important congenitally transmitted virus is Rubella virus, which is a member of Togaviridae family, which are pleomorphic enveloped viruses with single-stranded RNA. See, these are all the pleomorphism. Here you can see different morphologies of the virus you can see here, and they are also difficult to grow and but sometimes we can try with continuous cell line cultures known as RK13, rabbit kidney cell line culture, rabbit cell line kidney cell line cultures, and vero cell line cultures from the vervet monkey kidney also can be tried with, but difficult to grow. And if you see here, this is the morphology of this particular virus, which is enveloped virus, and the pleomorphic virus with single stranded RNA, belongs to the family Togaviridae. Survivors for this Rubella virus is human beings only who are suffering with the acute illness, and transmission occurs through the inhalation of respiratory secretions released from these patients, and they enter into the another's body by means of inhalation. So mode of transmission is or route of transmission is by means of inhalation, and respiratory secretions acts as source. And after an incubation period of 2 to 3 weeks, the people may be seen in the form of clinical manifestations. Pathogenesis: after the entity, it replicates in the nasopharyngeal cells and enters into the blood and produces viremia, and from there it reaches the skin and joints, either in the children and adults. And during the pregnancy, if it occurs during the pregnancy, it crosses the placenta and leads to chromosomal breakages and also the inhibition of mitosis in the embryonic cells. And so the cell division becomes slow and cell differentiation will get disordered, which results in the congenital abnormalities. And the target organs for this Rubella virus are the eyes, ears and heart. And mainly the congenital abnormalities are seen in these three areas or three organs if it infects the baby during the pregnancy. In case of postnatal rubella, that means if it occurs, when the infection transmission occurs after the birth, it may result in the form of mild exanthematous fever with the coryza, that's all upper respiratory tract infection like thing, this flu like thing, and common cold, headache and other things will be there with a maculopapular rash. And this is known as 3-day rash. See, this is known as 3-day rash and maculopapular rash. This postnatal rubella is also known as German measles. Measles is different, but this is German measles. And the auricular lymphadenopathy is present, which is painless. Painless posterior auricular lymphadenopathy is present, and it starts from, the rash will start from the forehead and spreads down. And in case of adults, you can see the arthralgia and arthritis. It's joint pains and joint inflammation also present here. And most important, and one most important thing is sometimes you can see the blueberry muffin lesions in this particular case also. This rash sometimes will appear bigger in size and produces like blueberries. So these blueberry muffin lesions also seen in case of postnatal rubella syndrome. Congenital rubella syndrome, it's the most severe complication among non-vaccinated pregnant women, which occurs in babies. So that's why usually all the female child are instructed to take this MMR vaccine at the 10 to 12 years age group. And it's this congenital rubella syndrome is more dangerous due to ignorance of this particular vaccine. And remember, this rubella virus is highly teratogenic. During the first trimester, 90% of the fetuses are affected, and risk is more up to 16 weeks of gestation. Up to 16 weeks of gestation, the congenital anomalies may occur, or teratogenic teratogenic infections will be severe, and the mortality is around 20% with this rubella viral infections. Rubella, as I mentioned already, it mainly affects the heart, eye, ear, and brain also. Here in the involvement of brain tissue results in mental retardation, microcephaly, and meningoencephalitis. And patent ductus arteriosus is another important congenital anomaly followed by this infection during pregnancy. Also, you can see the pulmonary stenosis, aortic stenosis, and ventricular septal defect and atrial septal defects. All these things may be present, but the commonest one is PDF, that's patent ductus arteriosus. And the cataract is another important congenital anomaly seen in the babies, followed by the soon after birth. And also the glaucoma and chorioretinitis also present. And in the ear, the sensory neural deafness is present with the involvement of ear. All these are congenital malformations with this rubella viral infections. Diagnosis, the serological test as well as clinical manifestations both will help for the diagnosis, and IgM and IgG rubella antibodies can be detected either by means of ELISA or any other methods available we can go. And PCR viral genome is most important for the confirmation of the diagnosis. And these IgM and IgG both are very important, especially during pregnancy. During pregnancy, we have to search for both IgM and IgG, because usually in case of to diagnose acute infection, we will go for IgM antibody estimation only. But in case of pregnant woman, we have to give importance even for IgG antibodies also. If the IgG antibody titers are in sufficient quantities or significant titers, then we have to consider this also. That indicates the pregnant woman already infected but not in active stage. But during the pregnancy, where the immunity will be decreased, there is a possibility for the reactivation of this virus and results in active infection. That's why in case of pregnancy, we have to give the value for both IgM and IgG antibody titers. We should not ignore that IgG indicates only old infection, so we can ignore. No, not like that in case of pregnant women. Just like the way you are giving importance for IgM, you have to give the importance for IgG antibody testing also. If it is positive, we have to closely monitor the pregnant woman for the appearance of IgM or any congenital anomalies to be occurring in during the pregnancy in the baby. And then the treatment, there is no specific treatment for this, and rubella immunoglobulins to the mother does not protect the baby. So even though you give the antibodies during the pregnancy, it never protects the baby. It may protect, of course, for the mother not to suffer with arthralgia and arthritis, but it's not useful at all to the baby. That's why always the screening is best for this rubella viral infections during the pregnancy. Epidemiological aspect, this infection is worldwide seen, and man is the only host available, and the communicability is more in the first week before and after the rash. Before and after the rash, this transmissibility is more 1 week before and 1 week after the appearance of rash, and outbreaks are occurring commonly among the school going children, and in the military recruit. That means overcrowding. The overcrowding is mainly responsible for the transmission of this particular viruses, and common during the spring season. It's very common during the spring season, and pandemics also possible with this rubella virus, but it will occur as for once in a 20 to 25 years. Prevention and control, the vaccine available is RA27 by 3, which is a live attenuated vaccine prepared from human diploid fibroblast cell line cultures. And all women of reproductive age have to receive this vaccine, and that's the first priority for vaccination receivers. And this vaccine is also preferable from 1 to 12 years of age. That usually we say there's 9 months to 12 years age group. People are preferable to receive this vaccine, and this is available either in the form of simple rubella vaccine, that's monovalent vaccine, or triple vaccine in the form of MMR vaccine. That's MMR stands for measles, mumps, and rubella. So this vaccine is available against all these 3 particular diseases, and single dose is sufficient by subcutaneous route, and it confers the immunity for about 10 years. But remember, it's a contraindicated during the pregnancy since it's in a live attenuated vaccine. Since this is a live attenuated vaccine, so it's not be given to the pregnant woman. The rubella virus and some of the viral infections causing for congenital anomalies. Okay, thank you very much.